musculoskeletal exam. Hopefully it's you understand it, and I'm gonna go through everything slowly, but you can make everything as fast as you need, like during the actual exam. And I'm gonna be looking at my notes because I haven't like actually studied it yet. Okay, so inspect C-spine. So basically from the occiput down. She's already kind of a little bit red because I was already palpating C7. But basically the first thing is before you even touch the patient is to inspect. And a lot of the way the musculoskeletal goes is it's inspect, palpate, then do range of motion, and then do special tests. And I'll like point out what the special tests could be in each one. So basically you're gonna inspect C-spine. I wrote down on here like looking for scars or torticollis, which means just like a weird angularity. Yeah, kind of like what Caitlin's doing right now. So C-spine, landmarks, hyoid bone, you guys know that. Posterior angle of the jaw, I think everyone kind of knows all about that. I'm trying to hold the sheet while I'm doing it. Mastoid process is back behind the ear. And then the TMJ, I think we're going to be holding them like this, right in front of their ear, and then asking them to open and close their jaw. Perfect. And then C7 posterior process. So this is the spinous process of C7 coat. So can you flex your neck for me? And it's going to be the most prominent one right up here. And 2 should be pretty prominent most of the time, depending on who the patient is. And then testing range of motion for C-spine. So flexion, Caitlin knows these, so she can do them. Extension, lateral bending. There you go, on both sides. Make sure they're not compensating in any way. And then, yeah, so you don't want to be having them lift the shoulder to the ear. That's not right. And then rotation. Yes, yeah, perfect. And then, I don't think we learned about Sperling's test, so I'm not going to do that. And then going down the line, thoracic spine is C7. So C7, can you flex? Yeah, C7, and then T1. T1 all the way down to L1 is the thoracic spine, so right in this location. And you're going to inspect again for curvature, hair, and pigmentation. And then L4, spinous process. So L4 is at the level of your iliac crest, right, Kate?
L4?
Yeah.
I'm not positive.
Okay. Well, we might need to look that up. Sorry. So here's our iliac crest. I can feel it and I'm touching it. And I'm going to come across. Can you bend forward? Yeah. So and you can stand back up. So once she's standing at the level right here, should be L1. And then L4 would be farther down. And you can palpate. And let's see. Palpate lumbosacral, so sacral spine. So sacroiliac joints are going to go like this, and it should be down in here. And you can palpate a very prominent like bony process on either side in the back. So her iliac crest comes up, and then it turns into the PSIS, which you can palpate on either side. And right underneath the PSIS is the sacroiliac spine. Or sacroiliac joint. Sacral spine is going to be farther down. I'm not going to palpate that. Coccyx, I'm not going to palpate that. And then sciatic notch. Can you show me, Caitlin, again? Right there. Right in here. It's a little bit further down from the PSIS. Right in the booty.
I think that one's easier to palpate when the patient's supine or prone.
When they're prone. Mm-hmm. Yes. And then we'll move all the way up to shoulder. So really you should be inspecting the shoulders bilaterally, atrophy, deformity, and carrying position. So sometimes you can have like a forward head posture, like when your head's forward. Yeah. Forward head posture, or like random things. Yeah, like shoulders rolled forward. We saw that a lot in our like swimmer, like athletes. And let's see. So you're gonna inspect the shoulders, then you're going to palpate, and basically I like to move from in to out. So I can see Caitlin's clavicles very well. So sternoclavicular, and I can palpate her clavicles all the way down. They should kind of curve around into an S shape. And once they dip off into her shoulder is where you have the AC joint. So I'm going to do one at a time. So there should be like a dip down, and this is her AC joint right here at the very end of her clavicle. Okay? And then obviously her scapula is in the back. Scapular spine is going to be a little bit higher up, right in here. All the way comes across. I'm trying to have you see it with my finger. It's a little bit more prominent. Let me see what else I need to show you. Coracoid process is going to be a little bit farther in. It's really hard to palpate, and it might cause them a lot of pain because there's a lot of muscles that like attach to it. Sorry, Caitlin.
You're good. But that's it.
But here it is right here. And then AC joint showed you that, sternoclavicular showed you that. Greater tubercle of the humerus should be, can you like twist your arm in and out? Okay, so stop. So I think greater tubercle is more medial, correct? Is lateral? Okay. So greater tubercle is going to be lateral, and when you have them twist their shoulder in and out, you'll feel like something snapping over your thumb. That's going to be the, you can stop, the groove. So pull it out again, or like rotate out, yeah. So here's the groove where I'm touching. It's very much in between two different points, so the greater trochanter and the lesser trochanter. And then when they like snap back and forth, that's going to be where you have the bicipital groove, and you have the long head of the biceps tendon.
Greater is medial because that's where all the
Greater is medial.
Yeah.
Okay. Yeah. So that was right.
To do external rotation.
Okay. Yeah. So greater tubercle medial, lesser tubercle lateral, biceps. Long head goes through that groove right there, and then also the short head is what attaches to the coracoid. And then I'm trying to think of anything else. Test range of motion of the shoulder. So Caitlin can do this for you. Flexion, extension. Don't let them compensate on those. And then you can go back. You're going to do abduction, adduction. I guess you can come across a little bit. Yeah. And then you can test this in multiple ways, but what I like to do is I like to stabilize their shoulder like this. Out. This is external rotation. Internal rotation. It kind of gets better when you get at this 90, and you can have them come in. Internal rotation, so she's got a little bit less than 90, and then external rotation, which she has more than 90. As long as it makes a 180 degree, it doesn't matter if they're short in any direction. And then, let's see, we do that. I don't think we learn any special tests for the shoulders. Inspect elbows bilaterally for swelling, deformity, carrying angle. If you remember carrying angle, women have more of a carrying angle, but it kind of is the way that the elbow comes out. So this is the angle, but it's going out. I think women is like 15 degrees, men is less. And then palpate elbow, so medial epicondyle, humerus, medial epicondyle, lateral epicondyle is on the outside over here, laterally. You can feel me, or you can see me palpating both of them at the same time. So medial and lateral. And then also olecranon process and the ulnar groove. So this is the olecranon process, very prominent. It's where the ulna sits in the humerus. And then, what was the other thing I said?
The ulnar.
The groove. The ulnar groove. So that should be, I'm trying to remember where that is.
Medial.
right? That's where the nerve sits.
Mm-hmm.
So ulnar groove is just medial to the olecranon process. And if you tap on that, she'll get some numbness and tingling down her arm. Yeah. And then, where was I? Test range of motion in elbow, so flexion, extension, pronation, supination. Nice. Both of those should be 90. And then test elbow, varus, and valgus stress. So this is one of the special tests I was talking about: inspection, palpation, range of motion, special tests. So she's gonna kind of relax for me, and you can do it at like full extension, but you're not gonna get very much movement. And then you can have her relax as much as she can. So this is varus test. You're stressing UCL, and then this is I said that was valgus test, right? And this is varus test. So stressing
I think you said
RCL.
varus the first time.
Okay, yes.
But
Sorry. Valgus, varus. And then, what was the other thing? Okay. So inspect wrist, palpate wrist. Radial styloid is going to be at the very end of the radius, right here. Ulnar styloid is going to be end of the ulna right here, where my thumb is. Very prominent, and definitely a little bit more proximal than the radial, and you can see them both on Caitlin. And then navicular or scaphoid bone, easiest to palpate if they have their thumb all the way up, and right in here. This is the anatomical snuff box in between both those tendons, both the extensor tendons. Extensor and abductor. Abductor pollicis longus and extensor pollicis brevis. That's a big question mark on those. Test range of motion in the hand, flexion.
Wrist or
Extension.
hand.
Oh yeah, sorry. Radial and ulnar deviation. Radial, that's ulnar, radial. And then we already did the snuff box. Inspect hands, palpate fingers. Thenar eminence is this big branch of musculature along the thumb. We learned in anatomy. Hypothenar eminence. And then MCPs, metacarpal phalangeals, is going to be all the way down the metacarpals until you hit right in here, this joint right here. Metacarpal phalangeals, proximal interphalangeal right in here, and then distal interphalangeal joint. Test range of motion of the fingers, flexion, extension, abduction, coming together, and then adduction. So sometimes I'll just push your fingers out,
Well, those would be opposite.
pull them in. Right.
Or it depends on the midline of the finger for which one's adduction, which one's abduction.
Right. And then opposition. And I think we test those again later on. Inspect hip alignment. So the hip alignment is kind of where I was talking about with the PSIS. So if I'm palpating her PSIS, this should probably be done earlier. So my fingers are both on her PSIS. It looks about level, and then it also looks about equidistant from the spine, which is what you want to see. Because her SI joint could be having an issue. And then, where was I at? Oh goodness. Anterior, superior iliac spine. I already palpated the iliac crest and the PSIS. And then, these are very, very easy to palpate. You can come across from the top of the crest, palpate right in the front right here on both sides. She's a little bit higher up on, well, she's okay. Her PSI was okay. Yes, she's good. Okay, and then ASIS, greater trochanter. is easier to palpate when you're laying on your side. So I'm gonna have her come back and forth. And then twist in. Okay, yeah. So the thing that's coming out at you when she's twisting, you can twist. I'm right on top of it. Twist out and back in. Yeah, so the thing that's coming out and like right there is right here, greater trochanter. When she does internal rotation, it's gonna pop out at you. So that'll be a good indication of that. And then, let's see, test range of motion of the hip. So flexion would be better if you were seated, but we can do extension. Well, yeah, we can do them both this way. You can do them so many different ways. So this is extension of the hip, and then flexion of the hip. Good. And then abduction is when she's gonna come out at me. And then adduction, I can show you with this one. So you have to move this leg out of the way and pull this one up a little bit. So you have to twist her around to do that. And then I just read opposition. I was like, I don't know what opposition of the hip is. And then internal rotation and external rotation is easier when she's seated. So do you want to take a seat really quick? And then we'll do the knee stuff. So it's easier if her legs are dangling, but this is going to be indicative of internal rotation, and this is going to be external rotation. So I think you should have more internal rotation than you do external rotation, which is fine. And then stand up again. Inspect knees for varus or valgus. So you can come around this way. So what I'm looking at is kind of the alignment of where her knees and her feet are in terms of her hips. So show me a little bit of varus if you can. Like her knees will come in, if you can. Yeah, and then yeah, there you go. So this is valgus, sorry. Valgus is when you come in. Varus is when you go out. And then hyperextension will be from this way. So she has a little bit, but not like overwhelming. And then swelling. Palpate knees. So patella is right here on top. And if she's not standing, I'd be able to kind of wiggle it around a little bit. But it's better to see right here. And then medial tibial condyle is going to be on the medial side. So right in here. So your tibia will sit right on top of, or right below your femur. And then lateral tibial condyle is going to be over here. Medial joint line, I mean, it's very easy for me to find just because like I can instantly go to it. But if you can palpate up her tibia, up to this condyle, and then it should fall off right in here. And it's harder to do when she's extended. So if she's flexed, it'll be a little bit easier to find. And they should have quite a bit of discomfort when you touch that area.
Another way to find the joint line is to find the eyes of the knee right here, like the two divots, and then just go around like that, like a C, and you're usually pretty close to the knee joint line. And then have them move to make sure that you're at it.
Yeah, and then Caitlin also showed you the lateral joint line. But sometimes they don't have too much space, but it should pop off right in here. It might take a little bit of practice. Tibial tubercle, right in front. Caitlin has a nice one right here. Fibular head is going to be kind of all the way around this side. And you can kind of see this on Caitlin. It pops over my finger right here. You'd expect it to be more anterior, but you need to come a little bit more posterior. And then medial femoral epicondyle, this big one right here that sits on the tibia, lateral femoral epicondyle. And then range of motion of the knees, flexion, which we would do if she was supine and she could flex all the way. And then extension. And extension you can do when she's seated like that on the chair and she can fully extend for me. But she's just laying down right now. And then inspect ankle or foot, medial, lateral, and metatarsals. Palpate ankle and foot. Okay, so this is gonna be a doozy. Calcaneus is your heel bone, back in here, all the way down in here. And then medial malleolus, right here, tibia. Lateral malleolus, here, fibula. First metatarsal joint, trying to figure out. Okay, so this is her metatarsal. Come all the way down in here. And then styloid process on the fifth. So this is actually one of my favorite landmarks to find. It's gonna be big notch right here at the end of her fifth metatarsal. So right here where my thumb is pressing. And then dome of the talus is gonna be kind of up in here. It's kind of hard to palpate, but it's basically where your ankle, I don't know how to describe that. Medial deltoid ligaments are gonna be right in here. So they're gonna come off right from the tibia and they attach all throughout here. So you're gonna have one behind, several forward. A lot of them will blow up in an eversion, ankle sprain. And then you're gonna have calcaneofibular. So basically, that's gonna be, sorry, yeah, I was right. Calcaneofibular is gonna be right in here. And then anterior talofibular is gonna be kind of up in here. Yeah. Basically from this forward to the talus. And this one will blow up if they have an inversion ankle sprain. And then posterior talofibular will be kind of back in here. So posterior calcaneofibular, anterior talofibular, so ATFL. Test range of motion of the ankle and feet, dorsiflexion, plantar flexion. I think that is it. I can't remember what else we learned. Do any of these other things sound familiar? I don't think that they do. Okay.
We can do a separate video with some special tests if we need to.
Yeah, if someone